Can everyone hear me?
Yes, sir.
All right, so let's start. Thank you for that kind introduction, and I'm really privileged to be here amidst my friends. And I know it's a Saturday evening, but it is my great honor to be associated with KREST over the years. And Dr. Kakalo Subrao had a very special place in my journey as a radiologist because he used to come to PGI Chandigarh very often as examiner, and me and my family were hosts to him several times whenever he was there. And he was a very good mentor and a very soft spoken and gentleman scholar who was very inspiring to me as a young faculty. So today we'll jump right into uh, imaging of the paranasal sinuses, and we are going to stress upon the overview of the CT anatomy and touch base with various nuanced approaches to looking at the anatomy of the of the paranasal sinuses, so as to get an informed decision about the surgical aspect of imaging of these structures, especially in light of functional endoscopic sinus surgery. So I have no disclosures, but I want to acknowledge grateful thanks to several of my colleagues, Dr. Bill Mash, Dr. Mark Zarek, he's a professor of ENT, Dr. Ashok Srinivasan, whom you may know, he is my colleague in the Department of Radiology. Dr. Remy Lobo is another of my colleagues, and Dr. Mohit Agarwal is a faculty at the Medical College of Wisconsin. Dr. Jeffrey Terrell is a world-renowned endoscopic sinus surgeon, and some of the images were taken from the MRSS rat primer textbook. So the objectives of the study are overview of the anatomy of the paranasal sinuses and to identify important landmarks with respect to FES and to outline some surgical perspectives and to review postoperative sinus imaging and review a bunch of complications. So the protocol for imaging is very well known to all. So remember that in the days of the old, we used to do direct coronal scanning of the patients lying prone in the gantry with the chin hyperextended, and the gantry was angled perpendicular to the heart palate, and we used to take 3 millimeter contiguous sections from the anterior wall of the sinus, frontal sinus to the posterior wall of the sphenoid sinus. And the FOV was adjusted to avoid the lens and metallic teeth fillings. It was kind of a discontinuous scanning, and and required some knowledge about the anatomy prior to the imaging, and if we had any luck, we could image all the landmarks. And the dosages were kind of higher than what is now recommended and what is practiced. With the advent of helical CT and multi-detector CT, the slice thickness got reduced to several sub-millimeter size thickness sections, and the radiation dose also was reduced because we could do the scan in a quick mode, and we could use the post-processing uh, uh, facility that was available after getting the scans in the axial plane to reconstruct the coronal and sagittal images. So this gave us a better insight into the anatomy of the paranasal sinuses, especially in the medial wall of the maxillary sinus and the orbits. So the newest technique, which is now being employed in several countries and even in India, is photon counting CT, which has got specialized detectors which resolve the energy of the photons incident to them. And then we can usually differentiate between tissue types, especially bone and contrast agents in a voxel. And also, it's an emerging technique, and there are very few articles related to head and neck available at the time of this review. So these are the two first examples of low dose photon counting CT for the paranasal sinuses, which was compared with cone beam studies. Cone beam are smaller machines which are used in dental practice, and the radiation dose is negligible to the patient, but we get a very good information about the bony anatomy of the paranasal sinuses on cone beam CT. So photon counting sort of is replacing cone beam CT at several places, although it's a full-fledged CT machine occupying as much area. But there are chances that newer machines will be available, which are more portable than the um, uh, existing uh, platforms. So we also did a related study on imaging of pediatric temple bone, and then compared with usual helical CT scans, and then the comparison of image quality was considered to be at par with conventional CT studies. So one should have a detailed knowledge about the anatomy of the penises, and before we actually start looking at the structures, and the reading pattern also has to be a little bit streamlined. So I understand each section of the paranasal sinuses so that the assessment is carried out in a very expert manner, and it takes a few minutes to go through the entire section once you have got the head for looking at the images. So it is it is a working knowledge that is important, because as you go and look at the images, you'll be aware that what the structure would look like on various orthogonal planes, even if you have an axial section to do with. So the idea about looking at the paranasal sinuses is threefold, because there are three major areas of stenosis or narrowing, which actually will tell you about sinus disease, especially chronic sinusitis. The first one is the drainage of the frontal sinus, and that's a narrow area here from the frontal epithelial recess to the egress of the secretions of the frontal sinuses into the anterior portion of the hiatus seminalis, which is the space just posterior, just lateral to the middle turbinate. And the superior margin of the middle turbinate bone from the ethmoid bone actually will demarcate that hiatus, which is a space through which several of the important structures will drain. The first of them, of course, is the frontal sinus I just mentioned, and the second one is the ethmoid bulla, which has got various uh, out punctate ostia for drainage of each of the ethmoid sinuses in the anterior ethmoid domain. And then the next important structure to drain into the hiatus seminalis is the maxillary sinus itself by its own ostium. So that is the second of the narrow spaces, the infundibulum or the maxillary sinus, which is a narrow space, which is the egress of the secretions from the maxillary sinus, which is in the anterior and inferior aspect of the hiatus seminalis. More posteriorly is the third narrow space, which is the sphenoethmoidal recess, which is the drainage point for the posterior ethmoid sinus and the sphenoid sinuses. So we will look at the drainage pathways individually in three different sets of slides for each of these narrow segments of the paranasal sinuses. So the first tight spot is the frontal recess, and its main constituents are the frontal sinus, the agar nasi, the nasofrontal process, which is the bony beak, which actually projects from the posterior aspect of the frontal bone and the nasal bone, which demarcates the frontoethmoidal recess and the middle meatus itself, which is the drainage point of the frontal sinus. So here we can see the major structures which we are interested in. The first is the frontal sinus. The second one is the attachment of the middle turbinate. Then the third process is the third area is the hiatus seminalis, and then you can have this area here, which is the drainage portion of the frontonasal duct. The largest cell of the ethmoid sinus which projects in the hiatus seminalis is the ethmoid bulla, which will be the drainage point for the anterior ethmoid sinus. So the first section which we need to go back and check on our CT images are these structures: the frontal sinus, the anterior portion of the ethmoid sinus, and the drainage of the frontoethmoidal recess into the hiatus seminalis. So here is the sagittal image here of a sinus study. And we can see that by fortune, the frontoethmoidal recess has been opacified. This is the partial aeration of the frontal sinus. This is the fluid in the frontoethmoidal recess. This is the frontal nasofrontal process. And then you can see the duct coming down here and going towards the hiatus seminolaris. And this is the middle turbinate. The middle turbinate is recognized on the sagittal images as a hanger-shaped structure here, which is shows the anterior bulla followed by the posteriorly located plate of bone, which is the grand lamella. The grand lamella is not, sometimes it is invaded by air cells, so the attachment to the roof of the ethmoid sinus here may sometimes be broken because of the aeration of the grand lamella itself. So the grand lamella, which is the attachment of the middle turbinate to the roof of the ethmoid sinus, is a leading landmark which we need to go back and assess. Anything posterior to the grand lamella are the posterior ethmoid air cells. And in the anteriormost portion of the cells in the anterior ethmoid sinus are termed as the agar cell. And sometimes these ones, like this in this situation, will try and invade the frontoethmoidal recess and the frontonasal duct here, as is shown in this particular reconstructed image in the sagittal plane. In the posterior projection in the coronal plane, you can see the opacification of the frontal sinus, and you can see the agar air cells coming up. And now we are seeing it in end phase, and that is actually trying to obstruct the frontonasal duct, and that is the reason why there is damming of secretions in the proximal portion of the frontal sinus here. In the coronal plane, you can also identify the middle turbinate and its attachment towards the roof of the ethmoid sinus. You can see the nasal septum and the medial wall of the maxillary sinus. And the opposite side frontal sinus is well aerated here, as you can see, and you can also delineate the inferior turbinate and the maxillary sinuses on either side of the midline. This is a separate patient which shows further anatomy, one section posterior to what we saw in the previous slide. And here you can see the roof of the ethmoid sinus, which is termed as the fovea ethmoidalis. And then there is a trough here, which is the site of the olfactory apparatus. And this is the area where you can see the cribriform plate. This is one of the areas which is of great importance to the surgeon, especially during FES, functional endoscopic sinus surgery, because the deeper this trough, the worse is or more are the chances of injury to the anterior skull base for which it forms a part. The perpendicular plate of bone you see in the center is the cribriform plate, and that delineates the olfactory groove per se, and you can see it on either side of this bony projection. This bony projection is termed as the crista galli. Here in this particular patient, you can see that there is this long process coming, which has got an air cell in it. This is the ethmoid bulla. This is the uncinate bulla, and this is the uncinate process. The uncinate process is important because it's part of the ethmoid bone, but in CT scan, the uncinate process appears as though it is attached to the medial wall of the maxillary sinus. I shall now, in a couple of slides, show you why that occurs and what is the reason why we don't see the uncinate process as a separate piece of bone from the ethmoid sinus. Here you can make out the middle turbinates and the inferior turbinates and the nasal septum in the midline. Another important structure which you see in the coronal plane, one step behind the expected location of the agar air cells, is the infraorbital canal. This is an important structure, and it has to be seen because it has implications for injury to the division of the fifth nerve, which resides at this level. The other important landmark which you see is this thin plate of bone, which is the lamina papyracea, which separates the orbital contents and the anterior portion of the ethmoid sinus. And on the other side, you can see that this is the uncinate process here. And this uncinate process is actually a perpendicular piece of bone coming from the ethmoid sinus. But the plane between the uncinate process and the medial wall of the maxillary sinus fits in like a Lego piece. So you just can't separate the two out with the resolution which we have on CT scans. But having said that, this uncinate process is important, and this is the first thing which the surgeon would try and remove so as to widen the egress of the secretions from the maxillary sinus. The opening of the maxillary sinus is bounded by this thin channel, which is termed as the infundibulum. For the sake of repetition, I just wanted to reiterate that all the sinuses which you saw do not have ostia which are dependent in the sense that they drain the fluid of by way of gravity. So the maxillary sinus infundibulum is situated high in the medial wall of the sinus. The frontal sinus drains into the nasal cavity via an opening which is more posterior directed and inferior. It is not the direct communication between the sinus per se, which is more laterally situated in the frontal bones. Similarly, the sphenoid sinuses, we'll see a little later, have the ostia which are located in the high wall of the sphenoid sinus, which again is not mechanically suitable for drainage by way of gravity. So there is a potential that any inflammation and any secretions which are going to be in the sinuses will remain in the sinuses unless and until the mucosa of the sinuses is functional. That is the crux of um, functional endoscopic sinus surgery. We preserve the function of the mucosa per se. The mucosa is pseudostratified ciliated epithelium, and the cilia of the mucosa have been programmed so that the secretions contained within the sinus are flicked over towards the natural ostia. So we will come to know the unscientific ways of the Yore, where the sinuses were actually drained by using methods related to the gravitational egress of secretions within the sinuses, which was considered to be unphysiologic. So coming back again, here again, remember this is the uncinate process is a part of the ethmoid bone, and it forms the lateral border of the egress of the maxillary sinus. Little more posteriorly, as you can see here in this particular instance, you can see the attachment of the middle turbinate to the fovea ethmoidalis, which is the roof of the ethmoid sinus. And you can see several air cells of the anterior ethmoid sinus coming in close proximity with the lamina papyracea. And you can make out that the edge of the uncinate process is coming and it's being pneumatized. So attachment of the uncinate process closer to the medial wall of the orbits is another danger spot because you can pull at the uncinate process while dissecting it out and then injure the medial wall of the orbit and create a subperiosteal hematoma, or you can create a fracture which can grow on its own and chronically result in prolapse of the extracorneal fat into the ethmoid sinus and cause changes in the overall alignment of the globes. In this particular instance, we can also see that the inferior turbinates have been resected and they appear to be blunted. But normally with the mucosa, they will appear as large globular structures, which are in the inferior portions of the nasal cavities. This is the same patient with the sagittal cutout and reconstruction. Here we again will reiterate the position of the frontal sinus. This is the frontal recess, and this is the frontonasal duct coming down here. These are the sets of cells which are termed as the aganasa, as like I said before, and this is the hiatus terminalis, which is bounded by the inferior edge of the middle turbinate, and you can again see the grand lamella or the basal lamella, which is attached to the roof of the ethmoid sinus or the ethmoid bone. And you can see the array of cells in the anterior ethmoid sinus, and these are the cells of the posterior ethmoid sinus, and this is the sphenoid sinus more posteriorly. So this potential space, which will come back later, is termed as the sphenoethmoidal recess. Coming to the next narrow position is the infundibulum or the middle meatus tight spot. Here, the structures which are of importance are the ethmoid bulla, the uncinate process, the infundibulum of the maxillary sinus. The middle terminates the hiatus semilunis and the retrobulbar bulla recess and the basal lamella, some of which we have already discussed in the previous study. This is a zoomed up cartoon showing the area of the ethmoid bulla and the cut surface of the middle turbinate. You can see that the several tiny ostia of the ethmoid cells drain in or around the vicinity of the bulla ethmoidalis. And this is the dependent space where the maxillary ostium will reside. In the cutout in the cartoon, you can see that this is the infundibulum of the maxillary sinus, which is the narrow portion. This is the portion of the ethmoid bulla. And you can see that this ethmoid bulla is closely approximated to the lamina papracea and the extraconal fat contained within the orbits. This is the diagrammatic representation of the ethmoid bone. You can see both the superior and inferior turbinate, which are cut out, and the scythe-like position of the uncinate process, which bounds the anterior margin of the hiatus semilunis. Supposing if we need to come into the nasal cavity and then we need to turn our endoscope to grab this edge of the ethmoid uncinate process and break this, break that uncinate process to widen the hiatus semilunis and then let the egress of the maxillary infundibulum to be widened. So that's one of the first tests we do when we are looking at relieving the obstruction to the maxillary sinus. When we are doing this, we are actually looking at and trying to preserve the middle turbinate. Sometimes the middle turbinate may have to be removed as well. So we need to go back and then widen this in entirety. And this is the area of the skull base. And these are the perforated appearing cribriform plates on either side of the midline. So this entire piece of bone is very important, save the superior turbinate here. So if you are doing anything and removing this part of the ethmoid bone, there is a chance that you are going to injure the anterior skull base, and also you are going to injure something more lateral to the uncinate process, which is the inferior aspect of the medial wall of the orbit as well. So that's important to just in your mind's eye look at that particular area of the scan, just to make sure that you can identify and clearly demarcate the uncinate process, and also look at its attachment to the medial wall of the orbit. This is how the uncinate process actually looks like. And this is the smooth edge of the uncinate process, which the surgeon will try and grip and break and fracture so that this area of the hiatus semilunis is widened, and then there is an automatic widening of the maxillary infundibulum. Again, to look at the middle meatus itself here, the boundaries are important again. This is the uncinate process. This is the middle turbinate and the attachment of the middle turbinate to the roof of the ethmoid sinus. So try and always see this particular area very clearly and look at any other cells which are here on the medial wall of the orbits to make sure that they are not too large or too close to the uncinate process. There should be a little bit of a gap between the uncinate process and the medial wall of the orbit, and that determines a lot of manipulation on the part of the surgeon so that he can get a clear plane of cleavage to open the ostia of the maxillary sinus, and also then make way for looking at the anterior surface of the anterior ethmoid air cells. So it should be very clear from this. So if you break this one, you land up in the next level of obstruction, which is the anterior portion of the ethmoid sinus. So you can do and go back and do an anti-ethmoidectomy by looking at and taking out the mucosa of those air cells and grabbing it and stay as close to the nasal septum as possible rather than more laterally towards the medial wall of the orbits. Here you can see that the large bulla ethmoidalis is closely approximated to the medial wall of the orbit, and any injury to the medial wall of the orbit can be facilitated by grabbing this particular structure and not looking at and not being aware of injuring this lamina prepucia, which is a thin piece of bone. It's barely even visible on CT. So the infundibulum here is very short. So if this is the edge of the uncinate process and it's closely approximated to the orbital margin, the chances are that there is no space here to grab this piece of bone to break it. So anything that is being manipulated at this particular level can result in making a hole in the junction between the medial wall and the floor of the orbit. So that is important to always sort of delineate and let the surgeon know about it. There is a secondary ostium in this case, which is kind of an anatomic variation. But notice here on the other side as well, this is the large bulla ethmoidalis, so sort of overhangs that secondary ostium as well. And there's hardly any space between this turbinate and the bulla ethmoidalis as well. So the entire middle meatus is compromised by these large bular cells on either side of the midline. So there is to be some degree of manipulation that is required to make space before we can reach the other part of the ethmoid sinus more posteriorly. Similarly, on the lateral sagittal projection, we can see that large bulla ethmoidalis here, which is actually partly pneumatized, which has partly pneumatized the grand lamella here. And you can see that this is an important structure. So if you're coming from here, trying to grab the uncinate process and trying to widen this area, you can easily injure the bulla ethmoidalis, which is very closely aligned to the lateral wall of the, more laterally with the medial wall of the orbits as well. Here again, I'm going to reiterate this anatomy. This is important. You can notice that this is the posterior ethmoid air cells because they are posterior to the grand lamella. And you can see that this is the sphenoid sinus, and this is the ostium of the sphenoid sinus, very high in the anterior wall of the sinus. So it is not letting the sinus drain normally in the sense that you will require some sort of a active process of the mucosa to shift all the secretions through this particular tiny hole here. This space between the posterior ethmoid sinuses and the sphenoid sinus is termed as the sphenoethmoid recess. Again, a new example here. Again, to reiterate the anterior drainage of the frontal sinus here through the frontonasal duct. These are the groups of cells which are termed as the agar nasi. This again is the anterior ethmoid air cells. This is the grand lamella or the basal lamella. This is the middle turbinate, and this is the hiatus seminolaris. So variation of the same theme again. And you can make sure that this is the posterior ethmoid air cells and portions of the sphenoid sinus here. In the axial sections, it shows a very nice pattern here, which is kind of very important for me because I think that apart from fingerprints, the shape and size of the ethmoid sinus are so unique to a single person that it is next to impossible to duplicate that in any other human being. Here you can see the opening of the sphenoid sinus. This is very high up in the section closer to the skull base. You can see the ostia of the sphenoid sinus going into the sphenoethmoid recess, and these are the posterior ethmoid air cells on either side of the midline. And this is the middle turbinate, and you can see how foreshortened and the attachment to the medial wall of the orbit as well as the roof of the ethmoid sinus. As they are coming up together, it forms some sort of a pyramid. So you can make sure that this sort of plate of bone is actually attached to the skull base. The important aspect of the highlighting the importance of the uncinate process is shown in these two cases where you can see that the uncinate process is closely approximated to the medial wall of the orbit here, and that has resulted in damming up of secretions because of the attenuation of the hiatus semilunis and the drainage of the ethmoid sinus. So this is a chronic process, and because of this chronic mucositis, you have thickening of the walls of the maxillary sinus, and the volume of the maxillary sinus is significantly smaller than the normally aerated left maxillary sinus in this instance. Here you can see that there is narrowing and um, pneumatization of that uncinate process has resulted in formation of a mucocele, and there has been a prior attempt to drain this maxillary sinus via the Caldwell Lux operation, and then that has been unsuccessful because of the non-physiologic approach to the sinus, and this mucocele has developed because of that, and there is this drainage, this damming of secretions within the small volume of the maxillary sinus. This has resulted in encroachment of the orbit as well. So this is a very dangerous situation here, because once you go back and try and break this pneumatized portion of the uncinate process, you're going to damage the medial wall of the orbit and create a hematoma there at that level. Here, the opposite is happening. There has been so close a space between the uncinate process and the wall of the orbit that it is going to be quite dangerous. And remember, this is also closely related to the infraorbital canal here. So damage to the division of the trigeminal nerve at this location cannot be entirely obviated. One of the most important dynamic measurements which the surgeons will always make is to look at the depth of that the cribriform plate, and this is termed as the KREST classification. The distance between the lateral aspect of the fovea ethmodalis and the floor of the anterior clinal fossa at the level of the cribriform plate is measured. And if this is a more safer measurement of 1 to 3 millimeters, because there's no chance of injuring the anterior clinal fossa floor. But here you can see that there's every chance that you may tug on this turbinate or tug on any of the air cells which are behind this, causing damage of the anterior clinal fossa floor. One of the other parameters which are also measured is to look at the relative height of the maxillary sinus and the ethmoid sinus. And this maxillary to ethmoid ratio is important because it will tell the surgeon as to what are the risks for doing any damage to the medial wall of the orbit as well as the anterior clinal fossa floor. And the golden rule is that more the ratio approaches 2:1, there's higher chances of injury to the ethmoidal structure and the anterior clinal fossa. So there is some sort of a unimodal distribution of the risks for injury to the floor of the anterior fossa because of that particular ratio, and is frequently measured. And there are other variations for measurement of the ethmoid sinuses as well. Coming to the last of the structures is the sphenoethmoidal recess tight spot, which is actually bounded by the superior turbinate and the sphenoid sinus. And then we have some important relationship with the medial aspect of the sphenoid bone, namely the optic nerve canal and the carotid canal. So this is the third area of narrowing, which is the sphenoid ostia and the sphenoid recess. For the sake of review, again, we see that that's that tiny space which is between the posterior ethmoid air cells and the sphenoid sinus, and this is the sphenoid ostium, which is non-dependent, and the secretions are facilitated to come out of the sinus by way of the mucosa of the sinuses itself. The important portion here to note is the superior turbinate, which is sometimes pneumatized and is closely approximated to the cribriform plate. So any damage or pulling at the superior turbinate has a good chance of injuring the cribriform plate, which lies medial to this turbinate. One of the important landmarks of the sphenoid sinus itself is the roof of the sphenoid sinus and the location of the superior and inferior orbital fissure. which are more anterior, but more posteriorly, we see there are several important structures which we need to go and look at. One of the most important ones are the optic foramen, and then this sort of an angulation between the medial wall of the sphenoid sinus and the potential space where the carotid siphon sits. So this is termed as the optocarotid recess or the lateral optocarotid recess. It is important to know that because sometimes the sphenoid sinus is pneumatized, and there are numerous cells within the sinuses which are termed as OD cells. So when you are approaching the sphenoid sinus, you're going to approach the sphenoid sinus anteriorly. So you need to go back and see what the mucosa is actually showing by way of looking at the bony profile previous to the positioning of your sphenoidotomy. So if you notice that there is an OD cell, you have to be very careful while breaking the septa which separate out these groups of OD cells in the left sphenoid sinus, because you can injure the optocarotid recess and you can cause injury to the carotid siphon. And these are real. I mean, you do see them, and I'll show you examples little later as to each of these important landmarks which we have just discussed. Sometimes it is very difficult for us to know if the infundibulum or any other structure which is closely approximated does contain some degree of pneumatization. So it's always better to go back and look at the PNS in the lung window, so which sort of negates out all the soft tissue and bony architecture and just shows the gas wherever it is or the air wherever it is. So it's one of the tricks of the trade to look for any obstruction here. For example, here the infundibulum is patterned, but here the infundibulum is not patterned. So you know that there is mucosal thickening, which is a potential cause for obstruction to that particular maxillary sinus. Virtual sinuscopy was designed just to have a overview of looking at the mucosa covered sinuses, which was delineated from the from the CT studies, and they look like something like this because it will just look as though the person is looking at the mucosa with the endoscope. And you can see for here that the right, this is the area of the hiatus semilunaris, and this is the ostium of the maxillary sinus, which is seen in the center and a magnified view. This is the another view of the sinus with the position of all the uh, tool to see the sinus opening. This was done way back in the 80s and 90s when we were at PGI. We were at PGI and we published a paper on looking at the sphenoid ostium and how the sphenoid ostium is looks like on virtual sinuscopy, and it was pretty well received at that time. So it's one of the pioneering works here done in India on 3D imaging. Coming again to the traditional sinus surgeries, the initial one was the Caldwell Lux, where you used to make a hole in the canine fossa and then try and drain the maxillary sinus. There was this external ethmoidectomy. We used to go back and remove portions of the medial wall of the orbit and try and focus and remove the ethmoid bulla. And then the frontal trifine, just making a hole in the anterior wall of the frontal sinus, trying to drain it through the widened nasofrontal duct, which was totally not a good thing to do anyways. So these were the traditional approaches, and we now no longer do these because we just go back and look at endoscopic sinus surgery and try and remove as much as of the normal variants to make the thing wider. For example, here we have removed the ethmoid uncinate process and also widened the infundibulum in doing so by doing a um, uh, turbinectomy as well. So this is the end results of endoscopic sinus surgery. So remember that it allows for mucociliary clearance because it follows the natural pathway for the ciliated columnar epithelium, but it also reduces the frequency and severity of infections, which can be controlled by non-surgical methods. So why should we image the post-op sinus? It's just to establish a baseline and also plan for any reoperation if it is needed. So there are indications for sinus surgery, and this slide has been provided by Dr. Ashok Srinivasan, and he had done an extensive surgery assessment of where the surgery is actually required, especially in cases of massive nasal polyposis, where there is recurrence rate is very high. We need to go back and redo several times so that the polyps don't return. And post-op care is important with steroids. But then there is autotogenic sinusitis, where the removal of the teeth and also looking at any functional drainage for the maxillary sinuses um, results in very low recurrence rate, and that also treats the dental abscesses. These are very common conditions. If you're doing head and neck radiology, I'm sure that you would have assessed these in your clinical practice. So it's always better to know the anatomy, so know what structures were removed, whether it was partial or total, and what is the nature of this the patent ostia that you have created. Here you can see for yourself that both the inferior turbinate has been removed. This is the middle turbinate has been removed on the left side, and you have removed uncinate processes on this side completely, but there is some degree of uncinate process which is left here because I think it is closely attached um, to the medial wall of the orbit. So you can see for yourself that it is the anatomy that is important, which you should know which is missing. Inferior turbinate is missing here, middle turbinate is missing here, uncinate process is missing here. So you know by natural instinct that what the surgeon has attempted to do. And of course, few of the cells of the anterior ethmoid air cells are also been de-roofed. And then the last but not the least, you should know whether there is residual or recurrent sinus opacification. So what are the planes of assessment? As I mentioned again and again, it's just by intuition. Unsinectomy in the middle meatus and antrostomies are done in the coronal plane, so you can see it. The frontal ethmoidal recess surgery, again, you have to see the duct of the frontal sinus and drainage of the frontal sinus, removal of the agar nasal air cell is seen on the sagittal sections, and by sphenoidotomy, you have to go back and see the sphenoid ostium on the axial and also in the sagittal plane. So here's an example of a quick look at the same patient we saw earlier on, where we have left the where we had where we left the structures which we saw in the initial slide. For the sake of time, let me go to the next slide, which will be important. I'm sorry about this. So so here we can see a status of a patient who has got extensive mucosal disease, and you can see the opacification of the maxillary sinuses and the fluid levels within the sphenoid sinuses. So what they have done here is there's bilateral unsinectomy, there is maxillary antrostomy and persistent sinus opacification, but no um, a bony formation of the ostia. Remember, it's an inflammatory process and there's osteitis, and that is the reason why you have new bone formation which occurs. I'll show an example here. So this is already, the surgeon has already made these changes, but we don't see any any abnormality per se, because it's actually covered with mucosa. So why has uh, the mucosal disease recurred? The recurrence has occurred because of scarring, which is can be only seen on endoscopy. So if the patient has already had an operation and you can see the changes of the operation, but you still see that there's persistent sinus disease, this scarring is important. And this is the way you can only see if you are in close cooperation with the surgeon who what he has done. And this cannot be predicted just by looking at the imaging alone. So there has to be a close cooperation between the surgeon as well as the radiologist to see what is the cause for failed um, surgical results. I mean, or not failed in the sense suboptimal surgical results would be a better option. Remember that the overarching desire for doing a FES is so that we can mitigate the disease process and reduce the chances for medication with steroids and so on and so forth. This is another example of a very interesting a phenomena which occurs. Just look at the middle turbinate here. If you look at the middle turbinate, this middle turbinate is sort of medialized to one side. And later on, what happens is because it's unsupported, it sort of migrates and becomes and sort of causes that obstruction to the sinus ostium which you have created. So again, just have a look at this. This is the middle turbinate and it's sort of medialized and sort of blocks this ostium that is created. So this medialization of the turbinates is important. And this you can always see if you have a clear idea that the patient's symptoms have not really resolved over a period of time. So this is termed as lateralization of the middle turbinate, and it is important to visualize that phenomena that occurs. So the middle turbinate is important. So in most instances, if there is a chances that this middle turbinate is hypertrophied, the surgeon will try and remove that turbinate so that there's more space in the middle meatus. So this lateralization of the middle turbinate, because it is drifting away towards the maxillary sinus, is an important phenomena which you need to. No. So this is what is required, and you can see for yourself that the right middle turbinate has been resected. Even then, there has been uh, an obstruction here because of the lateralization of the uncinate process, which you already seen in the previous slide. So what has happened here is that slowly over the period of time, or because of design, the uncinate process is left on, and then it sort of again comes more lateralized and some sticks towards the floor of the orbit, and then obstructs the natural aspect of the hiatus seminaris and the drainage of the maxillary sinus. Because of the extensive ossification which occurs because of thickening of the walls of the sinus, again, there can be changes which obstruct the natural ostia of the maxillary sinus specifically. And this is the instance where the patient had granulomatous polyangiitis, and that caused new osteogenesis because of the chronic inflammation. And you can see for yourself too that the opposite sinus, which is operated upon, does show thickening of the walls of the sinus. And this is a very important aspect which you need to stress on while you're looking at the maxillary sinus, which have been already operated upon, especially this. But it can occur in several other areas, especially in the frontoethmoidal recess, because of the chronic mucositis and the scarring that takes place following the debridement of the anterior ethmoid air cells. The other important aspect of surgery to the maxillary sinus is looking at mucosal disease which resemble neoplastic processes. For example, this is the area for attachment of the inverted papilloma. try and look for this telltale sign of for an inverted papilloma, and then we need to go back and remove that attachment, because if it is still there, you can see that the papilloma will recur, because of the nodal attachment of that particular area um, is still there for it to recur. One of the important features of endoscopic sinus surgery is persistence of symptoms following um, following extensive ethmoidectomy, and this is termed as empty nose syndrome. And this empty nose syndrome is caused by excessive nasal permeability, and it's neurosensitive to the receptors, and inhaled air humidification is impaired. And that is the reason why patients experience paradoxical nasal obstruction despite an otherwise clear nasal cavity and paranasal sinuses. So just remember this particular syndrome as well in case you are asked to image these patients who come with persistent symptoms following extensive but very good results on functional endoscopic surgeries. Next are a couple of cases which are from the file of Dr. Mohit Agarwal, one of our colleagues at the University of Wisconsin. These are very rare conditions which you can occur. So this is the importance of looking at the anatomy of the medial wall of the orbit and looking at the anatomical variations in the lamina pepraceae. As you can see, there's already some prolapse of the fat, and this is the abnormal appearance of the pneumatized portion of the fovea ethmoidalis bilaterally. So this is important to know, because if you pull at these structures, you will result in um, hematoma developing because of the fracture of the lamina pepraceae, as you can see from here. And you can see that the telltale signs of hemorrhage contained within the maxillary sinuses following the surgery. And also you can see the subperiosteal hemorrhage that occurs because of pulling at the ethmoid sinuses and sort of damaging the areas of the lamina pepraceae. So here is another example of what happens in the chronic instance, where you have done the de-roofing of the ethmoid sinus and clearing of the frontal sinus. And because of the changes in the contour of the lamina pepraceae, you can see that there has been a fracture, which is chronic, and this is resulted in the prolapse of the extracorneal fat. This is a classic case of looking at medial turbinectomies. Pulling the medial turbinectomy down fractures the grand lamella, and then that results in breakage of the cribriform plate. And this is a CT cystonogram, which shows the leak of the contrast through the damaged appearing cribriform plate. And you can see that this is the intact appearing olfactory bulb, and this olfactory bulb here is dysmorphic and injured. This is a most dreaded complication of endoscopic sinus surgery, where the optic carotid recess, which I showed you earlier on, has been pulled apart because of sphenoidotomies and clearing of the sphenoid sinus. This has injured the um, the carotid siphon, and the only way to deal with this is to pack the sinus, take the patient to the angiography suite, and actually sacrifice the entire extent of the internal carotid artery. Remember that this is an arterial hemorrhage. The arterial hemorrhage is at the normal blood pressure of 120/80. So you can see the amount of gushed blood that comes out, and the amount of panic that creates, because you are looking at a very small structure in a very small, concise space of the endoscope. So it is very difficult unless you just immediately do this. Otherwise, the patient will have a stroke and maybe exsanguinated and die if the thing is not managed effectively. The other important thing is to look at the extensive surgery that takes place. And once the mucosa of the ethmoid sinus is cleared, make sure that it doesn't contain bone and brain tissue because of damage to the roof of the ethmoid sinus. So this is another dreaded complication where there is gas seen throughout the anterior cranial fossa due to this large breach because of functional endoscopic sinus surgery to the ethmoid bone. The other important aspect of imaging is the localization of the areas which are important. For example, re-stressing the I'm just re-stressing the role of looking at abnormal alterations in the morphology and then comparing it with the pre-op situations to make sure that we remove the entire abnormality in total. Thank you for your attention. I think I took the exact amount of time because I had to rush towards the end, and hopefully you had a good overview of what we do for endoscopic sinus surgery. Thank you.
Oh, thank you so much, sir. That was a fantastic exposition, right from the anatomy to pathology to those scary complications of a seemingly simple surgery. Thank you so much. We invite questions or comments from the audience. We have senior radiologist, Dr. L.T. Kishore, Dr. Jyotsna, Dr. Jayalata, anyone, if you want. Dr. Rajgopal is here as well. Dr. Sri Krishna remembers you, Dr. Sir, your ex-colleague.
These complications are very rare. I mean, we hardly ever encounter in our practice here. So these were gleaned by Dr. Agarwal over several years. So it never usually occurs. We do get complications for endoscopic sinus surgery per se while we are dealing with surgeries to the pituitary gland, for instance, because that also is partly done endoscopically and partly done by bifrontal approaches. So if you're doing an endoscopic approach, there are chances that you'll encounter this sort of a complication, but not for sinus disease, in the sense that the pituitary tumors may be very large, and it may be sometimes very difficult for us to debulk the entire extent of the pituitary gland or pituitary tumor itself. So you need to go back and be very careful as to the lateral approach to the sella, especially if the sella is very large. And that makes it a little more challenging when you look at the floor of the sella protruding into the sphenoid sinus. So that to get that sort of space there by endoscopic approach.
Yeah, yes. So we had one complication of a carotid blowout due to sinus surgery, and the patient had a terrible bleeding during surgery, and we had to pack that off in the cath lab. But the patient succumbed 2 months later due to a fungal disease. The patient had a fungal sinusitis. Yeah, that's a scary condition. Yes. Yeah.
Fungal sinusitis is important because the nature of the periostitis that occurs, and also once I have a separate lecture on the MR imaging for paranasal sinuses, and we had encountered this large patient who had this mucormycosis, and then secondarily involving the anterior cranial fossa, and there were large abscesses which were present in the frontal lobe going all the way up to the striate cortex on the right side. So these are very tricky cases as well, because I think there was a recent paper also which we reviewed different types of fungus which occurs in the paranasal sinuses and in the CNS. And each of them has got their own peculiar ways of spread and diagnosis as well. And when I was at PGI, you may recall that the mycology department was the pioneer in looking at invasive fungal aspergillosis and allergic fungal aspergillosis. So two different conditions, but very different clinical pictures and very different imaging pictures as well. And I think Dr. Chakravarti, and he wrote a very good monograph, and it's world renowned and is respected in case of mycological aspects of paranasal sinus disease. And it is important that we know that as well.
There's one question in the chat box regarding any preparation for pre-CT of the PNS. We remember during the early 90s, where the patients were asked to blow their noses before before they came to the CT PNS. Do you advise any such precaution now as well?
Any of that anymore. In fact, nothing is, if the patient is on treatment, we just let them continue doing the treatment, and then we evolve it. We uh, we um, we see the natural evolution of the disease, and then once the favorable amount of time, or the time for antibiotic or steroid therapy is done, then we image the patient as is. We don't give any other instructions to the patient. um, so we have to know exactly what the clinical picture is compared to the imaging findings. The other important thing is that here we have stressed the importance of pre-op post-operative imaging, but the chances are that the surgeons will not do anything in any imaging for the post-operative patients. The reason is, he says that I've already created that space with me for the endoscope. All I have to do is to go and put an endoscope again and see very clearly. It's very easy to do in the operative, in the outpatient service. And if he suspects that there is some residual disease, then he will ask for, he or she will ask for imaging studies. But by and large, um, it is kind of being phased out in clinical practice, that we don't do any post-operative imaging as well. But it is important in my aspect to do is because patients come with recurrent symptoms and we don't know what the cause is. So I think that's a team's thing. It's a team thing which is done. Like every practice is different. Academic practices are different from private practice. Maybe the patient doesn't come back to the surgeon because he's well. So there is a lot of interaction between the surgeons and the radiologists when it comes to sinus imaging.
Sir, thank you so much, sir. It was so well presented. The cases were very good. Sir, I'm Dr. Jayalata.
Thank you.
Sir, I just had one encounter with one patient where the turbinectomy was, the operation went on with an ENT surgeon, but later, 2 weeks after that, she was still bleeding, and then there was some sort of exclusion of the fluid. So they went, they tried all sorts of antibiotics, and they went and saw endoscopy. There was a small cotton which was stuck up, which they put it as a swab, and it was deep seated, and that was removed, and she was fine, sir. That usually happens. That's what ENT people, because they little deeply put it, and then that will be not seen. And one more, just an observation, sir. We usually come across these tumor conditions where the paranasal sinuses are involved along with the sinusitis. And so at that times, it will be very difficult for us to differentiate the extension in spite of doing an imagiology with contrast, without contrast, and such conditions little difficult, I think. I don't, in our practice, sir. Just a
I
light
agree
of
with that.
that. Yes.
About foreign bodies and operations, I think whenever they do surgery, I don't have I should have shown the slide how the tray is arranged, but everything, the circulating nurse and the chief nurse who's there, she will count this number of swabs she's given
Yes.
to the patient. So I think that's important. And usually when this occurs, this is termed as a gossypioma, where the cotton swab is there and there's an
Yes,
abscess
sir.
around it.
Mm.
You see that in earlier neurosurgical practice as well. When we saw this, and there have been case reports a dime a dozen now. I think there's so many of these now that is there. But unusual in a sinus surgery, because it's a very clean surgery, and
Yes.
that is there. It's a reportable incident, and I think that should have been done. As
Uh,
far as looking at malignancies goes, it is always better to look at the bony outlines of sinuses as well. If there's any erosive changes,
yes, sir.
you that assessment. You have that assessment of looking at
Yes.
tumors,
Yes,
how
sir.
they And
They encroach on and then erosions associated.
so, and there are very clear-cut clinical as well as radiological findings for ethmoid sinus malignancies and maxillary sinus malignancies. In fact, the sinonasal tumor itself is a separate lecture on itself.
Entity altogether, yes, sir.
And there are guidelines which are available from the AGCC, the eighth, where you can make the diagnosis very reasonably so.
Yes.
Far as sinonasal malignancies goes, the only challenge is in
It's an
nasopharyngeal
associate, yes, sir.
So
The question is like when it is associated with the these fungal or non-fungal infections along with the tumor which is blocking it.
So I think that symptomatology following a course of antibiotic or appropriate antifungals is important. And then we reimage again and see if there's any changes there or not. But by and large, the quality of the imaging should be good enough for us to differentiate between osteitis secondary to inflammation and erosive changes due to malignancies. So I think that's another important thing which we need to go back and see. And then invariably, we don't just rely on CT. We have to get an MR done as well as for these
And that's
patients.
what I was just about to ask about the importance of the MR in such cases.
That's a different ballgame altogether because we'll be looking at perineural spread, especially along the division of the trigeminal nerve, and also looking at the floor of the anterior fossa for any intradural extension. Both these changes make it, N4, but doesn't T4. But I think those things are kind of different approach altogether. And I think a combination of CT and MR would be helpful in differentiating the two conditions.
Yes, sir. Thank you so much, sir. And during COVID, we had the opportunity to see so many paranasal sinuses imaging and various sorts of infections and so on, sir. Thank you, sir, for the excellent presentation.
Thank you, sir. Any other questions or comments?
Yeah, Ishwar, this is Dr. Kishore LT. Sir, your presentation was excellent. Paranasal sinus is also my favorite topic, but I learned few new things from you. Thank you very much. I probably, the question which I want to ask you have partly answered, but let me ask you that if you are imaging with CT and you have reason to believe that you are dealing with a tumor, what is the practice in your institute? Does the surgeon operate on the basis of CT alone, or invariably he asks for MRI?
No, invariably there will be a complementary MR that's done. We will the first person to tell them, there is something really amiss, especially in the pattern of erosive changes along the max of the sinus walls and any extra sinus involvement. I think that is important as well. Depending upon which sinus is involved, like in our practice, I think the sinonasal imaging primarily involves the ethmoid sinus, and those are telltale signs for destruction. And the thing is, there is something called functional sinus imaging as well. So we also do diffusion and perfusion weighted sequences for our suspected tumors. So once that is suspected, basically on clinical evaluation as well as radiological assessment prior to the MRI, that is another important aspect of imaging, and that should not be neglected. I mean, it is published data is there, although the thing is about functional imaging is that, there is no consensus, and that consensus has to be built up, on a national level as to what are the FA values which we need to go and show that this is really abnormal, and what are the range of FA values for benign and malignant conditions, and then stratify the malignant conditions based on the FA values as well. So I think that's functional, the ADC values. So I think that's another important thing which we need to go back and see, especially on that diffusion weighted and perfusion weighted imaging. For perfusion weighted imaging, we do DCE perfusion. So we know that there are certain parameters on the VE and VP maps, which will tell you that this is a malignancy and not an inflammatory process. So I think that's one important tool which we have for differentiating malignancies from benign lesions. And we were doing it, we still do it in cases of if there's any doubt, and then at least the final diagnosis will be done on endoscopic evaluation and then on histopathology.
Yeah, one small question. This accessory maxillary sinus opening, in your experience, do you think it sort of helps the patient in preventing sinusitis, or doesn't matter? I mean, they are also affected equally, like when they don't have the accessory sinus opening.
Yeah, the accessory sinus is just there. It doesn't really help in any way, because remember that sinus opening is unphysiologic. And we don't know the cause for that, whether that's actually acquired or congenital is very difficult for us to prove, and we never usually ask for that. So the chances are that if the patient is symptomatic, we tend to ignore that opening and then just do the conventional unsunectomy and widening of the infundibulum and antrostomies by functional endoscopic sinus surgeries. So we just ignore that signing. And remember that depending upon the extensive disease and also the anatomy which the surgeon will encounter, that will determine the opening of the maxillary antrostomy as well. So I think that comes with expertise.
Right. Thank you.
Thank you, sir. Is there any, what do you call a report template or a checklist, a standardized thing which is there for reporting on CT for sinus disease?
Yes, I'll share it with you on Monday. When I'm on clinical service, there is a template which we use for maxillofacial CTs, and it's a pretty comprehensive template. You can't miss it. So that, we tick on each of these things. So it's kind of a template that is built on a little bit more intuitive. It is not AI developed. It is humanly developed. So, we just make sure that we see everything. So normally the idea is how to see a CT scan for the maxillofacial region. I usually begin with the coronal scan because that's very easy to do, and then correlate each with them. You can put the coronal on one side and put the the axial sections on one side, and then use your localizer to go from level to level so that you know where you are actually in the axial plane. And then lastly, but not least, you have to get the sagittal paramedian section also open. So to see the natural ostia of the anterior ethmoid air cells and the frontoethmoidal anatomy very clearly. So once all these things are done, usually it takes not more than a couple of minutes to scroll through because of our expertise. I think several of you here are experienced neuroradiologists, so you should have no problem with that. So, since the axial sections are taken as the baseline, you can easily correlate and use a localizer to put all three together in one go and one PACS screen, and then scroll through the coronal and then get back to each and every level. So you begin with the anterior portion of the maxillary sinus, go up to the uncinate process and infundibulum. Thirdly, go back to the bulla, ethmoidalis, and then go more posteriorly till you see the superior turbinate and then the sphenoid sinus. So the way to know whether you're in the sphenoid sinus in the coronal plane is all the ethmoid septa are horizontally directed. So as soon as you see a vertically directed septa, you know that you're in the sphenoid sinus. And then, of course, the next big landmark is the anticlinoid process, the optic canal, and the planosphenoidal, and you're done. So I think it's very easy to do this very systematically. And I think anybody who's trained in PGI at my time, even Ishwar would do the same thing because it was done, the way it was done. And we did it on a Siemens. It was not even a helical scanner at that time. So we just use the third generation scanner to develop this sort of a methodology. And I've been following it up for now 30 years, 40 years.
Any more questions or comments? If there are none, thank you so much again, Dr. BAPURAJ. We look forward to more of your cutting edge newer insights into other areas of head and neck and neuroradiology as well sometime in the near future. Hope to see you in India next year in person.
Thank you so
Thank
much.
You so much.
Thank you.
Thanks.
Yeah, I'd love to come back again now that I have no more encumbrances. And I really enjoy